Hi, my name is Luciano. I'm going to talking about congenital cytomegalovirus infection. Definition. Congenital cytomegalovirus is a leading cause of congenital hearing loss in much of the world and a leading cause of neurodevelopmental disease. Infant babies can be born to women who are seropositive and seronegative prior to pregnancy. Symptoms vary from mild to severe, and hearing loss can be delayed in onset and progressive.
Congenital cytomegalovirus infection is the infection of a fetus with cytomegalovirus, or CMV, during intrauterine life. CMV is among the most common infections that cause defects during fetal development. It is often grouped with other bacteria, parasites, and viruses that cause similar illnesses in the newborn, known under the acronym TORCH, which includes toxoplasma, other pathogens, usually syphilis, rubella, cytomegalovirus, and herpes simplex virus. CMV belongs to the herpes viridae family of viruses. Herpes viruses are double-stranded DNA viruses which are surrounded by a lipid envelope. CMV is usually transmitted through contact with blood and other bodily fluids like breast milk, saliva, genital secretions, and urine of an infected person, or from transplanted organs. Congenital CMV infection occurs when a pregnant woman is infected by CMV for the first time during the pregnancy, or there's reactivation of an old infection, or reinfection with a new strain of CMV. The virus in the mother travels through the placenta to the growing fetus. The exact mechanism by which CMV causes infection and defects in the developing fetus is still unknown, but it's thought to be because of two things. First, CMV can be cytopathic, or cell damaging, as it replicates within the cells. It breaks down the cytoskeletons, which maintain the cell structure, which results in enlarged cells with intranuclear viral inclusion bodies, giving it the classic owl's eye appearance. It is also possible CMV slows down the process of mitosis, or cell division. Since mitosis helps drive the development of the fetus, tissue with infected cells might not grow properly. Second, CMV invades the endothelium of blood vessels, resulting in vasculitis, or inflammation of blood vessels. Vasculitis can affect placental as well as fetal blood vessels, causing narrowing of the vessel wall. And as a result, not enough blood flows to developing organs, causing abnormalities. Congenital CMV also increases the risk of intrauterine growth restriction, meaning the fetus does not grow well, or oligohydramnios or polyhydramnios, which is increased or decreased amniotic fluid. Most congenital CMV infections are asymptomatic or silent, with only 1 in 10 infected infants showing symptoms at birth. The most common clinical manifestations include petechiae, which is tiny purple, red, or brown spots on the skin, jaundice, when the skin, whites of the eyes, and mucous membranes turn yellow, hepatosplenomegaly, which is enlarged liver and spleen, and microcephaly, or an abnormally small head size due to an underdeveloped brain. The hallmark feature of congenital CMV is progressive, permanent sensory neural hearing loss, or deafness, which can present at birth or develop later in life. Congenital CMV is also associated with eye abnormalities such as chorioretinitis, or inflammation of the choroid and retina, strabismus, or muscle imbalance of the eyes, or cortical vision impairment. CMV also can cause intellectual disability, developmental delays, behavioral disorders, motor disabilities, and seizures.
Okay, applications in medicine. Postnatal diagnosis of congenital cytomegalovirus is done preferably via real-time polymerase chain reaction, oscillatory urine or both as soon as possible after birth and within 3 weeks after birth. Prenatal diagnosis is suspected case can be made with culture of PCR for CMV of the ionized fluid from amniocentesis because the virus can be detected in the urine of infected fetus that is excreted into the ionized fluid.
Most common clinical manifestations include petechiae, which is tiny purple, red, or brown spots on the skin, jaundice, when the skin, whites of the eyes, and mucous membranes turn yellow, hepatosplenomegaly, which is enlarged liver and spleen, and microcephaly, or an abnormally small head size due to an underdeveloped brain. The hallmark feature of congenital CMV is progressive, permanent sensory neural hearing loss, or deafness, which can present at birth or develop later in life. Congenital CMV is also associated with eye abnormalities such as chorioretinitis or inflammation of the choroid and retina, strabismus or muscle imbalance of the eyes, or cortical vision impairment. CMV also can cause intellectual disability, developmental delays, behavioral disorders, motor disabilities, and seizures. The diagnosis of congenital CMV infection can be made prenatally, before birth, or postnatally, after birth. Prenatal testing includes ultrasonography of the fetus to detect developmental anomalies, amniocentesis to obtain amniotic fluid for viral culture, or CMV PCR, or fetal blood sampling for CMV PCR, or cytomegalovirus specific IgM antibody measurement. After birth, diagnosis is confirmed by PCR or viral isolation from urine or saliva samples in newborns obtained under 3 weeks of age. A full physical examination of the baby should be done, looking for skin rashes, enlarged liver and spleen, and microcephaly. In addition, babies with congenital CMV should be screened for hearing loss at birth, and periodically during childhood and adolescence. Some hospitals will screen all babies for CMV who fail their newborn hearing screening, because CMV can cause congenital hearing loss. Other tests done to assess the extent of the infection may include a liver panel, which might show elevated liver transaminases or elevated bilirubin levels, a full blood count revealing thrombocytopenia, or low platelets. Neuroimaging of the brain by ultrasonography, unenhanced CT, or MRI may be done, which might detect intracranial calcifications, enlarged ventricles, polymicrogyria, lenticulostriate vasculopathy, or white matter disease. Treatment is usually reserved for symptomatic infants and includes antiviral medication.
Okay, pros and cons. Pros, vaccine development. Given the virtue of CMV in the environment and its substantial burden of infection, a vaccine against the virus would be an optimal tool for preventing congenital infections. An optimal goal is to confer immunity to CMV seronegative women and to also boost the immunity in CMV seropositive women where the burden on the disease is greatest. and common symptoms associated with congenital cytomegalovirus that can present at birth include thrombocytopenia, hepatosplenomegaly, intrauterine growth, restriction, hepatitis, CNS, and ocular disease, and sensorineural hearing loss.
Congenital CMV is one of the most prevalent infections, congenital infections in the world. It is associated with the risk of deafness, developmental disability, and unfortunately, as an obstetrician, we often see even stillbirth and fetal death related to congenital infection. There really are no effective treatments during pregnancy and no known prevention measures at this point that have been shown to be effective enough to really roll out across the nation or across the world. There is no existing CMV vaccine, which would be a major potential public health benefit, but we don't have that at this point. And we also don't have any in utero treatment options for infected fetuses. So we still have a lot of work to do on prevention of congenital CMV, as well as potential treatment options both in utero and postnatally for congenital CMV treatment. The one thing that I would say that was a takeaway from doing this trial was that we actually had to screen over 200,000 women to be able to find this rate of primary infection, which is many more patients screened than we had anticipated. And one of the things that we need to think of as a CMV community going forward is the potential to not only focus on primary CMV infection during pregnancy, but also women who are seropositive during pregnancy and attempts to decrease the rate of congenital infection among those women as well.
Okay, issue apply in Ecuador. In Ecuador, a way to prevent congenital cytomegalovirus prenatal control is important in pregnant women who should be vaccinated. In the case of not vaccinated, IgG and M tests should be performed to begin treatment.
There is two strategy to monitor, to address CMV impact in stem cell transplant recipients. We used to do more than 15, 20 years ago, a prophylactic strategy. What does it mean? Meaning at the start of after engraftment and after transplant and after engraftment, you start patient on one of the available drugs on the market from the get-go. Start them on the drug to prevent CMV reactivation. The problem with this strategy is you're exposing patients for a certain amount of time, usually up to 3 months, because this is the highest risk period for CMV infection. Expose them to a drug that could be potentially toxic with major side effect. And give you an example. Ganciclovir can cause myelosuppression. Valganciclovir also, which is the prodrug of ganciclovir, may have the same side effect. Foscarnet, another available drug, we know from experience and from many published studies, it has an impact on the kidney function and can cause nephrotoxicities as well as electrolyte imbalances and other serious side effects. Because of all these drawbacks of these drugs, we moved away from prophylactic regimen around 15 or 20 years ago, and now most of the centers, if not all, are doing preemptive therapy or preemptive strategy. And what I mean by that is If you have a good sensitive test like a molecular assays or even antigenemia, you test periodically, usually once a week or twice a week, for CMV in the blood, either at the time of the transplant or around the time of engraftment, and you look for CMV reactivation. Because patients with CMV reactivation may be asymptomatic. So that's why we do it periodically. We do it once a week, twice a week, even without symptoms. And as soon as we found a positive test above certain threshold that's defined a little bit differently in different centers in the US and in Europe, we start treatment. So we wait until we have a positive test above certain threshold, and we start treatment. Could be short duration treatment until patient respond to treatment and CMV viral load goes down or CMV antigenemia disappear. Then we may stop the treatment and continue preemptive therapy. The reason we start doing this kind of strategy for more than a decade, because this way we have less exposure to this toxic drug available for us on the market for at least 20 years now. Hoping for less incidence of side effect and major side effect from these drugs.
Okay, and finally, conclusion. Congenital cytomegalovirus is found in all communities around the world and has a disease burden that is greater than many better known diseases. While the majority of infants are born without symptoms, some of those infants develop hearing loss. Infants symptomatic at birth often develop long-term sequelae, including neurodevelopmental deficits. Advances are being made in prevention and treatment, however, improved awareness of the disease among clinicians and patients is needed. Thank you.